Good afternoon. Welcome to this EUDF Symposium. The title of the symposium is shown here, is the new face of diabetes. I think that we are really appreciating the diversity and heterogeneity of diabetes. And the EUDF, the European Diabetes Foundation Forum that I'm going to introduce to you in a moment, has been working on a recommendation for implementing disease-modifying therapies and tackling diabesity. So, European Diabetes Forum, what is it? I think that if you're here, most of you should know it. But let me just remind you what the EUDF is. The EUDF was started a few years ago, 6 years ago, Bart, correct me if I'm wrong, on the initiative of the ESD and the FSD in the attempt to really bring together all the voices with an interest in the field of diabetes in Europe. Just to really harmonize the voice, the request, the suggestion that we can provide to the political power, particularly at the European level, in order to keep the diabetes agenda on the table all the time long. And I think the idea was embraced by all the main stakeholders. You can see here the members of the EUDF, is the ESD and the FSD, and I have the great pleasure to really be chairing the EUDF for the past three years. We have the Federation of the Diabetes Nurses, the Breakthrough One Diabetes, the International Diabetes Federation, ISPAD, the Primary Care Diabetes in Europe, and Société Francophone du Diabète. So you can see there is really a strong representation. And along with that representation, we have also supporting collaborators, also because we are convinced that we need really to keep a dialogue with all the stakeholders and the pharma industry, the industry that is really developing all these new potential opportunities in diabetes are also important stakeholders that we need to deal with. Now, that is the organization. What does the EUDF do? Many things. The EUDF, since its inception, identify line of works, a line of recommendation. And what is typical about the activity of the EUDF is to really have a representation from each of the members to get together and elaborate on specific line, like, for instance, integrated care, data and registry, and we had a symposium this morning in collaboration with WHO on data and registry, digitalization, AI, and optimal use technology. And we'd like to invite you tomorrow to a spotlight session where we will be presenting the view of the EUDF on digitalization and technology and open it up to the discussion on the floor. Screening and early detection. And more recently, we also have activated two lines of action. And this is related to diabetes and obesity. You can condensate the two terms in diabetes, of course. And then to which extent the new opportunity that we have nowadays can really modify the trajectory of both type 1 and type 2 diabetes. All this in the light of a vision, of a mission that are reported here, and on the awareness that the number of people with diabetes in Europe is large and is unfortunately going to increase even further in the future. We do elaborate on those lines, of course, but those lines do need to have a target. And the main target is, as I said, the people that sit where decision can be taken. And I have really the pleasure and the privilege to mention to you that we have established a very nice communication with the European Parliament, with many of the European Parliament, and in particular with Mr. Valery, which is the Commissioner for the cardiovascular diabetes obesity plan. We have had the opportunity to meet with them on multiple occasions now, and we are really offering the view of the world of diabetes in building up a better care and a better protection of people with diabetes. And you can see here the contact with the presidency. You can see here the meeting we had last January, and you can see here Mr. Valery, the commissioner. So along with the work that we do with the European Parliament, we also have a collaboration, as you can see here, with WHO and other organizations. Now, this is at the European level, but we are also convinced that in Europe there are different situations, different settings, different political conditions. So each country has its own feature. So what we are trying to do is really to cascade down to each of the country the messages that are generated within the EUDF. And to this extent, we are working together with a similar organization that has been stemmed out from the EUDF in different countries. We had Belgium, Romania, Italy, Greece, and we will do even more because tomorrow night we will have another symposium, another meeting where we will be meeting all representatives of the main diabetes organization of almost all European countries. So again, to convey our message to them and to see any of these messages can be implemented in their country, or to allow them to prioritize those processes according to the specific country need. So today we are going to present what I was referring to just a moment ago, which is the work that has been done by a group of people within the EUDF in terms of analyzing which are the new phases of diabetes and what are the EUDF recommendations for implementing disease-modifying therapies and tackling diabetes. But in order to really do that, I would like to invite the chairman of this session, who is also the president of the European Association for the Study of Diabetes, and also the incoming president of the EUDF, because by the end of October, my term will come to an end. Thank you. Chantal?
Thank you very much, Stefano. And we have divided this session into two parts. One on disease-modifying therapies, specifically focusing on type 1 diabetes, and the other part on tackling the relationship between diabetes and obesity and how to really modify the disease there. We have been working in EUDF very hard in different strategic fora, and one of the outcome documents that we have generated is this paper, Disease-Modifying Therapies in Type 1 Diabetes, Preparing EU Health Systems for Innovative Treatments. And so I would ask Dr. Carmen Hurtado del Pozo, the Director of Research of Breakthrough T1D in Europe, to introduce our recommendations. Carmen.
Thank you, Chantal. Thank you, everyone, for attending to this important session. I'm Carmen Hurtado, Director of European Research, but also I'm a proud board member of EUDF. And I have the pleasure to really introduce and present to you the work that EUDF has been done in the last month around implementing disease-modifying therapies in the clinic in Europe. And I really hope that after this presentation, you can support this effort and help us to disseminate so we can really change the care of type 1 diabetes across Europe, a region that has one of the highest incidence in type 1 diabetes, and around 31,000 people develop type 1 diabetes every year, and we only have insulin to offer. And technology did an amazing step in improving the lives of the people for living with type 1 diabetes, but still, type 1 diabetes really fosters risks of many complications, including diabetes ketoacidosis. Unfortunately, the percentage of young people, but also adults that present with this condition at the hospital because they have not been diagnosed early on is still too high in Europe. And here also I'm going to put, if Chantal and also Bart allow me, to put my breakthrough T1D hat and said the big unmet need that is type 1 diabetes and cardiovascular complications. And this is really important that we really have to work on a really abandoned area. Because besides having a really metabolic control, type 1 diabetes also has the part of the autoimmune. And still, again, besides having a good glucometabolic control, people living with type 1 diabetes have a high risk to have complications in the eye, cardiovascular, kidney, and also foot and lower limb loss. But what are disease-modifying therapies? And here I'm smiling a little bit because over the year we have been having discussions with great experts, industry partners, and also patient associations. And the first meeting I remember, we spent 1 hour discussing what is really disease-modifying therapies, and everyone has an opinion. So here we refer what EME defines as the treatment that changes the progress of a long-term disease. Apply for type 1 diabetes means that you can really deliver treatment stage 1, stage 2, without really arriving to stage 3 when the symptoms are present. And why Europe must act now? We really are having a big momentum in Europe. And when you go to Brussels, and in the bubble Brussels that we all live, competitiveness is the magic word that they are using European Commission. And we really have to leverage from this moment. Europe cannot be behind. Europe cannot be behind in number of clinical trials. And I think now is the moment to really take the advantage and really implement disease-modifying therapies for type 1 diabetes. Talking about the specific policy momentum around diabetes is very clear. In November 2022, at the European Parliament, a resolution of diabetes was agreed with members of the European Parliament. EUDF Europe, together with the World Health Organization, have a joint declaration of diabetes. Now the EU Cardiovascular Health Plan is an excellent opportunity, and we just heard that diabetes is going to be one of the important factors in this plan. So our recommendations aim to support policymakers, healthcare professionals, and of course people living with type 1 diabetes, and stakeholders across the healthcare system by highlighting the regulatory, research, and workforce embeds. So the 3 key recommendations that we agree over this year is, first of all, prepare the healthcare system and also the professionals. Introduce early detection for type 1 diabetes is really a must if we really want to implement disease-modifying therapy. And strengthen research and ensure efficient regulatory pathways to support the development, evaluation, and approval of DNTs for type 1 diabetes. I will go over the next slides one by one. So prepare the healthcare system and professionals. I truly believe, and this is something that was also addressed at the opening of Chantal at ESC, like endocrinologists, we really need to stop having this insulinocentric point of view. Like there are more things coming and we have to be prepared. But in order to be prepared, we need to give them the resources that they need. We need to train healthcare professionals, and this is something also that Breakthrough T1D and the medical affairs team is really keen to provide, to train healthcare professionals, ensure healthcare facilities, establish care pathways, and also establish center of excellence and reference sites. And when I mean reference sites for disease-modifying therapy, I also want to refer to clinical sites, clinical trial sites. And if I have to mention an example, I cannot think of a better example than Innodia Network, who provides and is really attracting new clinical trials in Europe on disease-modifying therapies. The second recommendation introduced early detections of type 1 diabetes. It should be progressively implemented, but this is something that we have to act now, and we have to really work together to offer the possibility for relative, but not only relative, like general population, to offer the possibility to be screened to detect early type 1 diabetes. And of course, we cannot forget the patient perspective into the screening programs, and we should add it. I think we have plenty of screening practice, and just yesterday we heard the session of the consensus of screening, a really global effort. But if we look at Europe, we have the great example of Identify, who is aiming to screen 200,000 children over 8 European countries. We cannot forget about FRIDA as one of the pioneer screening programs in Europe. And of course, we cannot also forget about the great work that has been done in Italy with the new law on population-wide T1D screening. And all of that, and if we have disease-modifying therapy just knocking the door, is thanks to research. And we cannot forget about supporting research and advocate and say to European Commission, please keep funding clinical trials, keep funding clinical trial sites, because this is the fuel of everything what we are having now. Without research, we cannot really provide solutions for people living with type 1 diabetes. So all these recommendations will be presented to the European Parliament and to the European Commission on November 4th, thanks to member of the European Parliament, Stine Bosse. And here you can see the QR bar. If you want to really attend, I encourage you. It's going to be an amazing event. Denmark is now holding the presidency, and I think it's an excellent opportunity to really advocate for early detection and implementation across Europe. With all of that, I really want to thank all the members and experts of EUDF that has been working in the last month on this work stream. And also, please, here you have the QR code to really access the report that Chantal just showed you on paper. All of that. Thank you so much, everyone.
Thank you, Carmen. Carmen? Dear Carmen, join me here. We now have a round table, and Carmen and I will be joined by Dr. Sabine Hofer from Innsbruck, who is representing ISPAT, by Dr. Loredana Marcovecchio from Cambridge, by Dr. Sufjan Hussain from King's College London, and Dr. Alessandro Sorrentino, the Global Medical Head T1D and Cardiovascular at Sanofi. So do join us. And disease-modifying therapies. You've all been working on this document, and I have to remind the audience, scan the QR code, but also if you don't manage or didn't manage to scan it, you can go to the website of the EUDF, just type in European Diabetes Forum in Google or another search machine, and you will be able to get a whole wealth of documents there, including this one. So disease-modifying therapies, we all have our different approaches. Carmen is coming from Breakthrough T1D, so mainly from advocacy, if I can say, and also research. Sabine and Loredana being pediatricians, so you have this really very close to your heart. Sufjan, you are an adult endocrinologist, but also a person living with type 1 diabetes, so it's even closer to your heart.
Indeed.
And Alessandro, you are one of the manufacturers and the manufacturer of the first disease-modifying therapy already in our clinical hands in many countries. So we all come from different angles, but it is here, and it is coming very, very fast to the routine, probably. So, Sufjan, I will start with you as a clinician. How do you see the changes we will need in our minds as clinicians and in our healthcare systems and in the organization?
Absolutely. I think it's a really important question. And just echoing the point you made from my lived experience hat on, and I remember back in 2001, 10 years in my diagnosis, the whole concept of, hey, we'll have devices that connect to each other in closed-loop systems, we'll have all this progress in the genetics and be at a stage where we can prevent and delay type 1 diabetes onset, and islet transplant had just kicked off at that stage as well. And now it's real, it's really palpable, it's here with us. So I think we're in a really privileged position. Shifting back to your question, this is a really important part, that we as clinicians need to understand that insulin alone is not sufficient. The burden of the disease that type 1 diabetes carries, because of the intensive nature of its management, requires a lot of work, and the impact it has on lived experience, but also on outcomes. We know the risk that it carries. Insulin treatment is not enough, and therefore the ways in which we can either prevent the decline in one's own insulin production or regenerate it is really the way forwards. Culturally, in our mindset, that's not embedded yet. We need to move to a philosophy where we look at prevention, much like what our rheumatologists do. When someone comes with rheumatoid arthritis, they're not replacing the joint. They're actually tackling the autoimmune disease, similar to the hepatologist with autoimmune hepatitis. So that cultural mindset needs to shift. It's going to require an understanding. It's going to have aspects that we all need to work on. I know Breakthrough Type 1 Diabetes is also doing excellent work in the States. The project called MISA, Make Endocrinology Sexy Again. So, and this whole concept and ethos around the role of future diabetes physicians, as well as the wider multidisciplinary teams, in having roles that are beyond insulin, using things that can prevent and delay the onset of type 1, and hopefully also in the future regenerative medicine too.
How do we communicate these new concepts to those living with type 1 diabetes, the families living with type 1 diabetes, but also the general public? Sabine, you who are on the forefront of pediatric care, how will we have to adapt our communication, our narrative, to families who know T1D and families who don't?
Yeah, this is very important. Of course, it's easier to talk to families with a history in type 1 diabetes, because these families already know what type 1 diabetes is and what living with type 1 diabetes means. So they are more open for this information about how we rethink type 1 diabetes, and that we nowadays not diagnose diabetes with symptoms and hyperglycemia, but we now shifted the onset of type 1 diabetes to earlier stages. It's more difficult to talk about the community without having type 1 diabetes, and my approach would be here, or my thoughts to that is, there is no use to advertise. I think we need to get those physicians on board who have a trust with the families, so the family doctor, the general pediatrician. So we need to get those colleagues on board, and we need to spread the information we are getting here at EASD or also at the ISPAD meetings. It's now time to spread this information to family doctors and to pediatricians. And from my personal experience, I can tell you we started locally in Austria to do so. And surprisingly, the interest of general pediatricians was extremely high. So they are supportive. We just have to reach out to them. And this is important because a family builds trust with these doctors, and if the suggestion and the explanation comes from their side, then it's easier for those families to take this information than if it's someone they don't know.
Yeah, but you touch upon a very important point. if we want these primary care doctors, pediatricians, whatever, on board in our screening for early stage T1D, preparing eventually for disease-modifying therapies, we need to educate them. And only since, when did the ribbon figure come out? A couple of years ago. Only since a couple of years do we teach our medical students about these concepts. And so all the doctors of 30, 40, 50, 60 years out there, it's a new concept. So at this conference, there was a lot of education on early stage T1D. The rooms were packed. How do you do it in your country?
We have to implement this knowledge in the education plan for our medical schools and our universities. So it's now time to do so. So there is a redefinition of type 1 diabetes, and I think all those doctors from tomorrow, so those who are in our medical schools now, who are at university studying medicine now, they need to be educated how we now think of type 1 diabetes, and that the diagnosis type 1 diabetes has shifted from symptoms and hyperglycemia or dysglycemia, has shifted to robust and confirmed antibody positive tests.
I'm a bad chair. I forgot to welcome the 90 people online, so welcome online. And also forgot to say, you can put questions in the app, and we will have some time also for live Q&A at the end of our panel. But Loredana, I want to come to you. You have been involved in screening for early stage T1D, but you've mainly been involved in clinical trials using disease-modifying therapies in individuals with newly diagnosed stage 3 T1D. How did you manage to recruit the number of people you recruited? Young children, down to the age of 5 in the MELD-ATG trial. How do you approach the concept of disease-modifying therapies in a family?
Well, this is an important point. It's also an important point because you need to deal with that, during a critical time, which is soon after, a diagnosis of type 1 diabetes, which is not maybe the right time, because you already need to discuss, insulin therapy, all the implications of this new diagnosis, and then you need also to rush it, discuss a study, a trial, because you want to recruit. But I think it's important really to be open. It's important to raise awareness, to really explain what is available there to the families. Because, if you really have a clear dialogue with them, explain, pros, cons, and really also it's important to also have them on board and, make sure that they know that they are contributing towards the future, we need their help to progress in terms of research. I think if you have an open communication, most families are ready to try something new, because we all will tell them that okay, insulin is there. I always say we are lucky that we have got a treatment, but it's not a cure. And parents, really parents of young children really wants to try something different, something which could, maybe in a few months make these children insulin free.
So how, you mentioned an important point. Until now, we always are confronted with introducing the potential of disease-modifying therapies in a crisis situation, where we need to bring other information. Children, but also in adults, that's always our problem. And then 3-4 months later, when everything sinks in, they contact us again and say, can we participate? And then it's too late. So how important will it be to go towards the early detection?
I think we have heard a lot about that. I think that will really, as we have heard, will really allow us to, to the family, to prepare the family, to have time to have this conversation when, and everything is quieter, it's not a crisis. And I think what is essential is really we need to raise awareness, starting about awareness about why we are doing screening, why is important early detection, why is important, that they are ready to try these new treatments, which, as any new treatments, everyone is a bit scared, mainly when you deal with children, but, there are treatments with a hope. I think that is important to highlight. But definitely this is why we need to focus on the importance of early detection, which is one of the actions, so to have really a standardized uniform screening program to identify these people well in advance, to have time to prepare them. Maybe these days we say prepare mainly them to the transition to insulin, but we need to prepare them to the transition to disease-modifying therapies.
Yeah. Sufyan, you live in London. You work in a multicultural, multi-ethnic society. How will we do this? Because people from every ethnicity can develop type 1 diabetes. So how to communicate about screening in these populations, but also about the introduction of disease-modifying therapies, let alone trials in diverse populations?
I'm really glad you touched on that question, because it's really a topic that's close to my heart. And first is a humble plea to industry, to academics, to ensure wider inclusion in your studies, because that is not happening at the moment. And ways to do that, to encourage that, need to be thought through, because that's where we will then be able to understand the cultural aspects that need to be brought into the support materials, into those conversations, into those discussions, because this is the very group, when it comes to situations, whether it was a rollout of vaccines, whether it's rollout of other situations, it was the one it's harder to reach. And it's going to be a challenge, and we're going to create more disparities if we don't tackle this now.
Absolutely. Alessandro, why does industry care about type 1 diabetes?
I think, when you look at the history, and of course I have the privilege of working for a company like Sanofi. Sanofi has a history of more than 100 years commitment in diabetes. And of course, with the acquisition of Prevention Bio that we did a few years ago, there has been a strong interest from our company, but in general, for the pharma industry about type 1 diabetes. Type 1 diabetes as an autoimmune condition, it's something that has not been treated as an autoimmune condition. And I would say that we are in the age of immunotherapies that already started, as you said correctly, around 20 years ago. And at the moment, there is so much research ongoing that we can actually hope to provide in the future with solution. And we as a pharmaceutical industry are, of course, constantly committed, not only Sanofi, but also I would say the entire pharmaceutical industry, to find innovative solutions for patients. And I really like what you said as well about preventive therapy, so the idea of treating patients earlier. So I believe, coming from, in my career, I come from around 20 years experience in immunology and actually rheumatology and all the other indications. So, and we have seen a huge shift in treatment from conventional therapies to biologics. And step by step, there is always the idea, okay, can we treat early RA now? Can we treat early lupus now? And last year, you were at the Bridge Summit, Chantal. We actually invited in our events a rheumatologist that tell the story of how the rheumatoid arthritis has been treated, how this has changed. And then I remember very well, he said, we as rheumatologists now are completely committed and understand why treating at the mechanism of action of the disease is much more important, is much better. But he also said something that, in my opinion, all diabetologists needs to keep in mind, that you have probably the only specialty of an autoimmune disease that have the possibility, hopefully in the future, to treat a condition before the symptoms happen. And this is no other disease can do it. So I would say that the way I look at it, and also why I think this is such an interesting field, scientifically and medically, is that diabetes, specifically type 1 diabetes, has the opportunity to rewrite the book about how an autoimmune disease is treated. Because when we treat much earlier, then we can avoid organ damage. And avoiding organ damage and preventing organ damage is the goal for any autoimmune condition. So I would say that we see the huge unmet need, we see the science is taking us in the right direction, and hopefully we will be able to take new medications to help people living with type 1 diabetes.
You have a view of what is happening in industry in this domain. How do you see the pipelines? Will industry engaged, you think? Will more and more industry come? Is there a rich pipeline, you think?
Yeah, absolutely. I mean, when you look at the amount of clinical trials that are happening now in type 1 diabetes, we see that these are increasing more and more. And I think for me, working for Sanofi, it was quite interesting. One of our in EUDF meetings, when actually I met some of the other colleagues, and they told us, look, in the beginning, type 1 diabetes is very difficult, no one has really managed, but then we saw the great commitment that Sanofi is doing, and now actually we want to go in. So I think it's also to generate this positive cycle, and I do see this happening in the industry. But of course, to make this happen, and this is something that we discussed very much into this white paper, there is a strong need from the society, from the healthcare system, to be prepared. And this means, as it was said before, to really encourage screening, because there is a way to identify these patients that, coming to the example of rheumatology, we do know that it's complicated to do the antibody test, it's not done everywhere, but it's 4 autoantibodies. If you want to discover early lupus, I had the opportunity to work in lupus, you need to do a genetic RNA test of, I don't remember how many hundreds of genes, and then you will have a genetic risk score. I mean, it's very complex. So there is a lot of things that can be done here. But if I may add one thing as well from the healthcare system perspective, when in the future disease-modifying therapies hopefully will come to Europe as well, there is a need for the healthcare system to be ready. This means to have referral pathways in place, to have center of excellence that are ready to take this patient, to have system for monitoring. And what is super exciting, both from the industry, but in general for me that I've been working in healthcare for so many years, is to see this conference and everyone speaking about it, seeing the excitement, seeing your word at the presidential. I was telling to Chantal, I really loved her presidential speech yesterday, because it looks at the future. It looks at, you're not anymore, endocrinologists looking at the metabolic effect of a disease. Many of what I think in the future, many endocrinologists will be immunoendocrinologists, interventional diabetologists. And that's why I'm super excited to hear about all the courses we are planning to do. I think, you can be really at the forefront of immunology. And we are happy as Sanofi to be part of this journey together with you.
Yeah, and secretly, we hope that also the other fields of endocrinology will follow. Because if you think of it, we as endocrinologists are undertakers. We replace dead organs. And so imagine if also in thyroid, in adrenal, it may be a whole new world. But the pediatricians, how will you adapt your clinics? How will you do it? Will you make screening clinics, or will you ask that to the primary care, and will you do the early stage T1D clinics and disease-modifying therapies more with the specialists? How do you see it, Sabine?
Well, we heard yesterday about comment and consensus about how screening programs can be set up, and we have all those experiences now on different nations, how they set up their screening systems or all the also research screening systems. And I think it's also an advantage now, if we now try to translate the best out of that into our national screening systems. This is now time to discuss that. And also, again, I would vote to introduce or include the family doctors and pediatricians, because they already do screenings. If I speak for Austria here, we do have national screenings. And we could, or maybe we should try to find time spots when to include it in already existing screening time points. So this is the work we have to do. There are issues we have to tackle, for example, resources, like all of us, I guess, have to do that. And we need to talk to our health care authorities. We need to talk to our politicians. And this might be the tough part of it. I mean, we all know that it's not a huge budget around. So these are things I think are the the great challenges we have within our community. I think it's a lot of work already done, and the consensus that it is important and that we should establish a national screening program. This is quite far, but now getting all those who have the money to pay for it and the healthcare authorities on our side, I think that might be the most challenging part and next step.
Yeah. Loredana, disease-modifying therapies, once they're outside of the trials, how will you organize your clinic? Will the pediatric endocrinologists and their nurses and teams do it, or will you refer them to the oncology department, or how will you do it?
Well, I think we need to think about a new clinical pathway, yeah? I think that will be the main work we need to do in the coming years, which will be both maybe for monitoring children, young people identified at risk, as well as to implement the disease-modifying therapies. I think you need a sort of multidisciplinary approach, for sure. I think as pediatric endocrinologists, we need to be there at the front line. I don't think we can send to other professionals, but for sure I think we can learn from the oncologists, we can learn from our colleagues for rheumatology. I think this is what I think most of us are already doing in starting those conversations, to develop a sort of a collaborative approach, to learn from them and see how we can develop our infusion clinic as well as our diabetes, pre-type 1 diabetes clinics. Yeah. But I think this is essential. And again, we need also to collaborate with primary care physicians, because we need to have everyone on board. So.
Carmen, the word pay and money, etc., fell. So how can pressure groups, sorry for calling Breakthrough T1D that, but also our local diabetes associations, people with lived experience, how can they play a role to demand disease-modifying therapies for type 1 diabetes and not be put off like I was put off, this is not cancer, thus it is not so important. So how can you play a role? What can we say? How can you harness us?
Advocacy is such a hard work, right? I think that the only way that we can is just what EUDF is also doing. Talking with members of the European Parliament, making sure that they understand what type 1 diabetes is. They don't even can differentiate, many of them, what is type 1 diabetes, what is type 2 diabetes. So how we can even start talking to them about screening. So, and also we have to be very clear and send them, I think as an academics too, sometimes we think that they understand. We also have to send clear message, accurate. They have to be really accurate, but also when we say, and this is something that came actually in a discussion with Esther the other day, when we say DKA, diabetes ketoacidosis, they don't know what it is. But, okay, but then if I say, be in the UC with a 2-year-old boy or girl, kind of using a language that allows them to empathize in a way. And this is kind of the only way that we can really convince policymakers and also politicians that unfortunately are the one taking the decision. But we're walking a tightrope. We just published last week, I think, the lexicon of Identify about the terminology we propose to use. When talking about early stage T1D, call it early stage T1D, stage 1, stage 2, preclinical, pre-symptomatic, whatever. And call it a disease. And Jurgen Verkouteren, who is responsible for Identify, nearly got attacked by some people living with type 1 diabetes saying, no, it's a condition, it's not a disease. So, Sufyan, how can we find the right balance between illustrating to politicians what diabetic ketoacidosis is and that people die and that diabetes is not a nice disease to live with, and still have this balance of not making all of our people with type 1 diabetes depressed and angry? How to find the balance?
It's a very interesting question, which I think is a complex answer, but I think it ultimately boils down to which audience are we speaking to and what the intention of the discussion is. But you're absolutely right that if we frame it to our policymakers, because we want to make this an emotive topic, we want to convey the urgency, we want to convey that inertia and them not making decisions or not moving down a path will lead to lives lost, will lead to burden. We have to communicate that with a sense of urgency, and that's the only way we can do it for the greater good. But of course, in the clinic room, when speaking to the individuals, speaking to the families, we have to do it with a very different tone. And I have to play that same role when I'm speaking to politicians or when I'm speaking to families in front of me. It's very different language, but you're right. It's difficult to come with a one-size-fits-all tone.
Yeah, and another group we need to talk to again, Carmen, and also you, Alessandro, is the regulators. For them to understand why we need disease-modifying therapies and what we mean, and what a meaningful endpoint is. So I know Breakthrough T1D works very hard on that. So what can we do better? How can we inform and work with the regulators better?
Actually, I don't know if our director of regulatory is here, but I wanted to just tell you what happened just recently. EMA opened a consultation for autoimmune disease. Type 1 diabetes wasn't listed there. He wrote to EMA, and the response was like, well, Type 1 diabetes is just handled by diabetes cardiovascular metabolic disorder.
And you know who is there? Cardiologists.
I know. So you know. It's really, I mean, we are really trying, we are really pushing, but just seeing Type 1 diabetes not listed in autoimmune disease by EMA say everything. Another really big roadblock that I'm seeing in Europe is the fragmentation. Not only as the regulatory agencies, I'm just talking even afterwards, the health technology assessment bodies. It's a nightmare for companies. It's really a nightmare for really attract innovation here. So I think we also really need to advocate for a unique market in Europe. It's the only way that companies don't go to other countries to run clinical trials.
Yeah, there is hope. EMA, for instance, has partnered with EASD. Also, EUDF is a partner. And EASD, for instance, they work with us and asking for experts in all of their consultancy. So I'm honestly a big fan of EMA. I think they have great potential. But Type 1 is, yeah, it's sitting between two chairs.
Maybe if I may also comment, and I do completely agree. I mean, in my career, I had a lot of relationship with regulators, and EMA, FDA, they have a lot of extremely experienced people, with which is always, very easy to have a dialogue and a conversation. So we highly value, I think, the conversation that we have with super experienced people that are in the regulatory authorities. Now comes to the end point, I think it really goes back to the idea of about defining diabetes type 1, not only as a metabolic condition, but about an immunology disease. Because otherwise, of course, I mean, you think about HbA1c, you think about glucose level, but that's not what disease-modifying therapy necessarily are for. I mean, they are actually there to act at the core of the condition. Preserving beta cells and preserving organ is what in any other immunologic autoimmune condition, what is the final goal. So I think the work that you are doing, Chantal, and all the community to move forward, and maybe people understand this is an autoimmune condition, we need to treat the core of the disease, probably in the future will also be helpful in discussion with the regulators.
How do you see the evolution of, I mean, now disease-modifying therapies, we're jumping up and down with joy that at least we have one coming soon, hopefully also to Europe. How do you see this evolution towards personalized therapies? Do you see any possibilities
Yeah,
there?
absolutely. I can tell you, of course, that we at Sanofi, we are absolutely working in this direction. We will hopefully to have some results. I know from other colleagues in pharma that they are also going into the same direction, because we understand that this is not the same for every patient. So I believe that if we find a way to have personalized medicine, we should absolutely use it. Now, are we there yet? No, we are not there yet. But I can tell you, we are doing a lot of research in this direction. And also the way that I look, considering that many disease-modifying therapies are coming, is that probably there will be not one drug that works. Maybe there will, you use one for a while, you can maybe exhaust one mechanism of action, you start with another one. There could be combinations. There's the same thing that happens in rheumatoid arthritis or in Crohn's disease. We know very well that methotrexate plus TNF-alpha is better TNF-alpha alone. So, or there are, different things that you can do together. Or when one biologic stops working for primary or secondary reasons, then you can use another one. That's why I think stimulating research is so important, because if we keep on preventing the damage, then I think we can ensure a long period of disease-free to the patients until, of course, a cure doesn't come. And I really hope that also we move in that direction in the future.
Yeah, that's what ESD with EFSD tries to do. We have a few minutes left in our time on disease-modifying therapies in type 1 diabetes. I will open the floor to questions from the audience. Online, I see no questions. Any questions for us to ask? Yes, please. Esther.
Yeah. So just a couple of comments when I heard the definition of disease and condition. I think there's a clear definition of what a disease and what a condition is. So I think they're already established. So we can just refer to what's defined as a condition and a disease.
As a non-native English speaker, I don't feel it.
The definition. I thought there's a different when you know the mechanism, when you know the symptoms, when you know much more. So disease is part of the umbrella of a condition, right? So I'm not going to get into that, but just there are definitions for some. And then I just want to just mention that Breakthrough T1D is obviously very strong on advocacy, but as Carmen mentioned, we're a research organization, and we need to provide data in order to, when we present and make arguments for advocacy, that we have the data supporting that. So it goes both ways, like what additional data, what research data we need to support moving forward for screening, for disease modifying, for cell therapies. But I think just making a point that Carmen mentioned in the beginning, research and providing data to support all the advocacy work is very important.
Fully agree.
Just a comment on that. I think it's more about the emotive perception that the word disease carries to people with type 1, which is why they prefer to use the term condition, as it implies a more livable entity. However, the flip side is, when you're speaking to politicians, that emotive term can convey a sense of urgency, a sense that this is something that does need to be tackled in priority. So I think that's where it's more the perception rather than the actual, the meaning of it.
Yeah, absolutely. I will end by asking Loredana, you are in the board of, as are some of us, of EUDF, a network of clinical trial sites all over Europe, trying to indeed get clinical trials to Europe about disease-modifying therapies in type 1 diabetes. How important is collaborating?
I think that is really a key word, so creating a collaborative network, I think, is the strength of EUDF as well as other maybe consortium around the world. So, but within Europe, EUDF has really created a strength, trying to even improving that, creating a collaborative network of clinical sites, which, should, in order to make sure that they are there is a site almost everywhere at the moment able to deliver clinical trials, and hopefully in the near future then implement these disease-modifying therapies in clinical practice. And what is important is to make sure that there are not just 2 or 3 sites which are excellent and able to deliver treatments, because what we want to do, we want to avoid that there will be inequality in access. Just because a person lives in a specific area won't be allowed to receive these treatments when available. So I think that is the strength, creating collaboration support between centers. And then I think the other strength also that Inodia has created is creating a sort of patient-centric approach. So making sure that, when developing trials, designing trials, or implementing trials, we hear the voice of people living with diabetes, and I think soon we need to hear the voice of people living with early stages type 1 diabetes to see how they want this trial to be run the best way, and also which is the best way of implementing these therapies, how to present that to their peers with the same condition.
Yeah. So thank you very much for this panel. It's amazing that we're able to discuss this topic now. Imagine 5 years ago even, we wouldn't be here with an almost full room, so amazing. Thank you very, very much for this lively panel. Thank you. So I hand over the chair to my colleague, Professor Stefano Del Prato.
Thank you, Chantal. Thank you very much. As Chantal already mentioned, we have decided to split the session into two parts. The first one was mainly, as you heard, devoted to type 1 diabetes. And the second one is really moving to another part, which is more related to type 2 diabetes, and in particular, the interplay between diabetes and obesity. Again, we will have my friend Jean-François Gauthier to introduce what has been the work, the collaborative work, and really like to underline again the collaborative work, because what is going to be presented is not Jean-François work, but it's the work of all the representatives of the different members of the EUDF, and then we will have a round table. Jean-François Gauthier is the past president of the Société Francophone du Diabète and a member of the board of the ESD. Please, Jean-François.
Thank you, Stefano. This is a great honor for me to be here, and I will give you what we produced as a member of the EU Strategic Forum on this relationship between obesity and diabetes. So we, as Carmen said and Chantal said, the problem is that we need to speak clearly to policymakers. That means that we need to be understandable. And so it's the reason I'm sorry, but these slides are not for diabetologists and health professionals. These are dedicated for our MEPs. So diabetes and obesity are deeply interconnected and rapidly rising in terms of, in the EU. And you can see on the right side of the slide that the number of people living with diabetes is equivalent to the population of Netherlands, Portugal, and Croatia combined. So it's a huge population of individuals living with this condition. The risk of developing type 2 diabetes is 7-fold higher among people living with obesity. 90% of people with type 2 diabetes also live with obesity, or at least central obesity. But also, what is a little bit alarming is in type 1 diabetes, children and adolescents display obesity in between 20 and 30% of them. So, and also diabetes and obesity also have significant implications for women's reproductive health and care. And as Stefano said, diabetes and obesity share many risk factors and complications, and this is the reason why we used to call this condition diabesity. So it's really clear for us that the EU and member states must adopt holistic policies that simultaneously address both conditions, diabetes, obesity, and their complications. So Carmen already showed you this slide just to highlight some emblematic numbers. 30% of people living with diabetes will have vision loss during their lifetime. This condition is a major cause of lower limb amputation. Diabetes is also the main cause of end-stage kidney disease, and also, as it is very well known, it multiplies by between 2 and 4 the risk of cardiovascular disease. So for all type of diabetes, risk can be reduced if the condition is detected early and well managed. So these conditions are very, very costly, and we cannot sustain anymore all the costs related to obesity, diabetes, and their complications. Over more than 600,000 people die because of diabetes each year in the EU. Diabetes, obesity, and related complications together cost 240 billion euros every year, and that includes direct cost, health direct cost, but also indirect cost. And the vast majority of these costs are preventable. So we estimate that every euro invested in diabetes management yields 5 euros in return. So it is an important thing to have in mind. So the EU and member states must target diabetes and obesity to save lives, improve quality of life, and make health systems and economies more sustainable. So the group proposed 6 recommendations to target the interplay of obesity and diabetes. First, national plans. 2, have interdisciplinary care. 3rd, reduce stigma. Prevention. 4th. 5, health checks. And 6, which is very important, have equitable access to healthcare for everybody, even in poor people. So I'd just like to go over these 6 recommendations, but it will be short. So we need a plan for effective action at the level of national state. So how we can do that? Establish appropriately funded national plans for diabetes prevention, diagnosis, and treatment that integrate obesity management throughout the care pathways and include the development of adequate disease registries. The problem of disease registries has been already discussed in other sessions during the Congress. And this plan should include measurable milestones, timelines, and accountability mechanism to ensure implementation. And sometimes things that our politicians do not know how to do, or how we can evaluate what we are doing. Second, we need to have interdisciplinary care. This is the only way to have really an integrated care. And also it allows to get rid of siloed approaches. So how to do it? Establishing specialized clinics with interdisciplinary teams. This is obvious. Physicians, nurses, dietitians, psychologists, and so on. We need to update clinical guidelines. And third, we need to integrate care into healthcare professional, educational, curricula, and training. This has been already discussed previously, to implement those guidelines and promote the use of diabetes and or obesity management technologies. Reduce stigma. Stigma, it's very important, and it is a fact. So we need to reduce stigma through healthcare professional educational programs and also public awareness raising campaign. 4, we need to prioritize prevention because prevention is better than cure. So how we do it? Taking action, prioritize prevention of diabetes and in complications through a body weight life course approach, obesity management and lifestyle intervention with a particular focus, of course, on young people. So the sooner, the better. Joint health check. It's very, very often, the cardiologist, he don't care about, other risk factor. It's not always the case, but we have a lot, as a clinician, very often the cardiologist call us the day where the patient is leaving the hospital, said, okay, I think he's diabetic, can you do something? So it's very important to check to check all the condition if the individual has a condition. For example, in obesity, we need to check for diabetes or prediabetes and for cardiovascular risk factor, etc. So systematically assess people with obesity for prediabetes and diabetes, systematically assess people with prediabetes, diabetes, and obesity for cardiovascular risk. The goal is that we need to have to provide the individual early holistic treatment. And last, equitable access. Provide the right treatment for the right person at the right time. This is like a motto of the EUDF. Eliminate legislative and systematic barriers to ensure equitable access to care. EMA-approved treatment and technologies for all population, including underserved communities, and also support treatment adherence. So this recommendation has been presented to a EU Parliament. It was, if I remember well, the 24th of June, and you can recognize, I don't know if you, on the screen, it was our health commissioner who was, introducing the commission, and this commission was under the supervision of Professor Morino, who was with a member, MEP, a member of the Health Commission. So thank you very much for your attention.
Thank you very much, Jean-François. Yes, please have a seat. So Jean-François has brilliantly summarized long hours of work, and that work has been resulted in this document here. If anyone has any specific interest to go through it, he can scan the QR code and can get the entire document. The document includes what has been presented by Jean-François, but also it's reporting some national good practices that are already available and operating that could represent a starting point. Now, and this is the starting point of the roundtable as well. And it's my pleasure to invite on the stage Professor Timo Müller. Timo is at the core of the modifying therapies because not only has been instrumental to some of the treatment we have nowadays, but it's also looking into the future with a great hope. Please have a seat, Timo. Also, I'd like to invite Gabriel Quattrocasas. Gabriel is a primary care physician, but with a lot of interest in diabetes and research in the field of diabetes. But it's a key because he can also bring the voice of the primary care in this approach to really modify the history of the interplay between diabetes and obesity. And I have to make to amend here, because I said before that this may be more on the side of the type 2, but thank you very much, Jean-François, to bring out also the issue that obesity is also generating major problem and is becoming more and more common even in people with type 1 diabetes. So when we talk about breaking the interplay, it's not just type 2 and obesity, but also type 1 and obesity. Finally, also I'd like to invite Eugenia Vlachou. Eugenia is a professor nurse with a lot of experience in nutrition, but also a great advocate of gender medicine, and she can also contribute to our discussion here today. Now, we've been speaking about modifying therapies, and therapies really comes from industry. And it's my pleasure to invite Dr. Henrik Jarlov from Novo Nordisk and Dr. Georgios Dimitriadis from Eli Lilly. They also are invited to bring to us their view on the issue that we're going to discuss. Okay, so targeting the interplay between diabetes and obesity. So maybe I can start with Timo. Timo, very close interlinked condition, the need to really have a more comprehensive approach, but still, I think that we are still lagging behind quite a lot. What's your view, and what could be done at the European level? What's his view on this?
Yeah, so I think one of the current limitations that we have is that we tend to look at different diseases as independent entities, right? So when the patient comes to the doctor and has a cardiovascular disease, he gets treated for the cardiovascular disease. If he comes with an increased HbA1c, he gets treated for his diabetes. If he comes with higher cholesterol, he gets treated with statins, right? But the root cause, or the key problem, is that we tend to treat the consequences but not the causes of the disease. And one of the root causes of all of these diseases is obesity. And while we happily, eagerly, and very good treat patients with different diseases, we, for some reasons, are still hesitant to treat obesity as the core root that gives rise to other diseases. And it is important that we increase the awareness on all societal, political levels that treating obesity is not a cosmetic problem, or it's not a cosmetic therapy. By treating obesity, we are actively preventing the disease development and progression of very devastating comorbidities. And I think this awareness has to be increased dramatically, because we can decrease health costs in the long run substantially. And there is absolutely no reason why we should wait until a patient shows a fatty liver disease or a cardiac event before we treat this secondary event, if we can already treat the primary event, which is obesity, right? And we are now living in very luxury times where we have biological tools to make that happen. We could have had the same discussion 20 years ago, right? 20 years ago, we also knew that obesity is bad for you. We just didn't have the tools to treat the patients, at least not in the way that we have it today. So today is time that we are able to help the broader population of patients that are in medical need to decrease body weight. And now it's our job now to make that happen.
It looks to me there is a sort of analogy from the discussion we just had in terms of type 1 diabetes, because what has been brought up before was that we do not need to treat hyperglycemia, but rather to treat what is the pathogenetic mechanism leading to. Maybe obesity is a disease by itself, but definitely is a major cause for the progression toward diabetes, which will also impose a further burden to people, in that case. So maybe we need to have a change in the mentality here in our approach. But following up with that, what kind of a strategy would you suggest? We're working within the EUDF. The EUDF has the ambition to really provide or suggest potential, approaches to this. How would you suggest?
So I think the first step is actually to increase awareness. Everybody has to understand that obesity is not the result of a lack of willpower. It is a chronic disease. The desire to eat and the accumulation of excess body fat due to overeating is mediated in a way that it's not the lack of willpower that leads to obesity. The second is that we need to bring all the different expertises together so that we increase the awareness that treatment of obesity is also treatment of cardiovascular diseases, right? So we need an interdisciplinary approach where we need to create awareness that obesity is not even a twin epidemic with diabetes. It's a risk factor. It's a risk factor for the development of so many comorbidities and linked diseases. We didn't even touch on the neurodegenerative diseases, right? So also Alzheimer, Parkinson. There are so many diseases that directly result from an excess of body fat. Right? Diabetes is, of course, one of the most prominent one. Cardiovascular diseases is another one. So we need to create awareness on all levels that investing early on in the prevention of obesity is, in the long run, not only saving a lot of money, but also improving health benefits for the patients, improving that our society works as a society, because we can use the money for better things than treating diseases that we could have prevented 5 years earlier, right? And increasing the awareness, bringing the right people together, I think this is the first step forward.
And also let me invite our panelists, if you have anything specific you'd like to bring up during the discussion, please, intervene. Now, Timo, you have been really emphasizing the need of a comprehensive approach. Nowadays, it's a holistic approach. Maybe it's an abused term. It's an abused term for a very specific reason, at least to my eyes. Who's in charge of it? Who's in charge of the process?
Well, I think...
You give me your answer, but then I want to hear a specific question. Is the primary care physician the one that maybe should be in charge of the, keeping the pieces together? Because, as you pointed out, we are not treating a disease. We are helping a person, and that person may have different issues. So, Timo, and then I'll ask Gabriel to give his opinion.
So, I think it's all of our responsibility, right? And that was actually basically the reason why we founded our forum, right? This was the reason why who if not we, and when if not now, right? So we all have a shared responsibility here, and I think it's our responsibility to reach out also to other societies, cardiovascular societies, renal societies, and I'm pretty sure that they are also aware of the problem, and we just need a spark and a set of people willing to take the first step, and then I'm pretty sure we will be successful here.
Gabriel.
Yes, so let me add and to point out 3 main areas that I think that as primary care professionals we can produce and add help there. I think that the first idea is that we have to better define where the value lies exactly, even beyond weight and even beyond the definition of obesity and beyond glucose and even beyond the definition of type 2 diabetes. So that means when we consider both conditions, that really shares a huge entanglement, really we are facing a huge tsunami of diseases. And of course, it's not possible for us as primary care clinicians to really attend all this huge amount of patients. So we will need new strategies, for sure, the interdisciplinary teams, for sure. And with the help of technology, it could be a good tool to have in our consultations, but also focusing in managing these conditions in a more agile way, because we have a lot of constraints around time, etc. So education in between our colleagues in primary care setting in order to harmonize the messages, the concepts between nurses, pediatricians, physicians, nutritionists, etc. So perhaps we can boost this approach to this new wave of diseases with even point of care testing, point of care devices. So we can do better, of course, but it's time also to harmonize our messages. And the second important point that I want to really highlight is that we have also to construct bridges with the community. That means bridges with pharmacies, with food providers, with educational centers, and so on. Because many times we have the sensation that we are praying in the desert and we are rowing against the stream. So it's, under my point of view, is of utmost importance at least to try. I think it's tough to do that, but it's an important measure to really try to push around our community with the same messages. And another important, the last but not least important message that I want to bring out here to you is the long-term durability of all these efforts and all these benefits that is supposed that now we can reach. So we have, because of the experience before of the diabetes and mainly with GLP-1s, analogs and so on, this kind of drugs, that the benefit is much less than expected compared to clinical trials. So I think another key point that we have to improve is to really have in our routine care practice, we have to be embedded of this conception of follow-up. So perhaps we have to also provide patients education. We have to also perhaps manage technology, reminders, something like that. Introduce new posologies or of new drugs, and so on. But we have to keep in mind this long-term view is really a very critical point.
Yeah, no, I think that you're perfectly right. And also, if I can play the devil advocate, we need not to get, let's say, the community, the population, just to rely on the drug as a way to escape other potential, solution or concomitant lifestyle modification and so on and so forth. Because what we need to explore, is something, what is the long-term effect of this treatment and so on and so forth, and to which extent, this treatment can be used temporarily or at interval in order to, but in the meantime, you need to really reinforce the process. Education probably is the key. Education is in the hand of many people. Maybe the nurses can help here. Can I ask you, Eugenia? So what could be your role? How do you see the role of the nurse in this integrated approach? And the approach is made of effective pharmacological intervention, education, and maybe also some other maneuvers that may be required in a system that should be less obesogenic than it is right now?
Yes, of course. Let's remind you, of course, all we know that integrated care is coordinated, continuous, and holistic support at the individual. To me, it means in practice that every patient is never left alone through the healthcare system. And it is the nurse who makes connection from the hospital to primary care and community services. And nurses, we know that are in the front line, so they spend more time with every patient and make sure that make the treatment plans more translated into the real world, not only scientifically sound, but more practical to the real life, because there is a gap between scientific knowledge and real life. So nurses are more willing to spend more time than physicians. And of course, they are in the community, so they can early detect and provide information, run campaigns for weight management, and refer to the physicians as soon as possible. But what I want to say that is the important role of a nurse is that the connection, not only with the healthcare system, but through the specialist, not only with physicians, but and other healthcare professionals such as psychologists, dietitians, and every healthcare provider in obesity and diabetes. And of course, integrated care is very valuable because every professional can contribute his knowledge, and it is the nurse as key link to ensure that everything is holding together.
So I think that what you are suggesting, the nurse can play a pivotal role in that really keeping the contact and the prompt contact between the medical part in general, that could be including all the different specialists, and the person with obesity and diabetes.
Yes. Actually, without the active involvement of nurses, integrated care is simply not very possible, if I may say.
Yeah, of course. You can say it, definitely. You can say that clear and loud, for sure. So we heard, the scientist, the physician, the primary care, the nurse, but also we have the industry. And actually, it is merit of the industry that we are here now to discuss for potential modifying therapy for diseases. I think that Timo already alluded. But sometimes, there are problems in really having the innovation to be laid down into the system. So how do you see over the situation? What from your point of view, what could be a suggestion to really make the process to go on in quicker and smoother? So can I ask you, Henrik, so what's your view on this?
Yeah, and thank you for the invitation to also be part of this discussion. I think from our perspective in industry, luckily we see a lot of the same challenges, right? A lot of the recommendations that have been brought forward by EUDF aligns completely with what we see. And I would say three things are remarkable where we see that there needs to be a change, and also where I think industry can play a large role in being part of that push and solution. The first thing is what Timo also pushed, and which is apparent here clearly, that these are interlinked diseases: obesity, cardiovascular disease, and diabetes. And it's recognized by clinicians, Unfortunately, on a healthcare system level and on a regulatory and on a payer level, it's not always the case. They still see it as distinctly diabetes, obesity, or cardiovascular disease. And from an industry perspective, that means that we have to push development through those lines. I would applaud some of my peers in industry who have actually taken the approach to drive clinical trials that focus on multimorbidity. I think that's one way that industry can be part of driving that awareness that these are interlinked diseases. Then the second part, I think, which is important, is also what has been mentioned here, that there is early intervention, and that it's recognized that early intervention matters, and again, that these diseases are overlapping. And a large part of that is also industry. We can be part of driving clinical research and clinical trials that demonstrate benefit of early intervention. And there we also have examples from different industry pharma companies that are driving these early intervention studies, which links maybe to my third point, which is that we need evidence generation in long term and from a broader perspective. And that was also part of the recommendation on the national plans to ensure that there is proper registries that can capture long-term outcomes. Because ultimately, if we have to improve access to these medications, it's also about demonstrating economic value to society at large. And the only way we can do that is with evidence and large data sets. And industry is, of course, an important partner in that, but we really also need clinicians, societies, etc., to create robust evidence from real-world practice. So those would be my three perspectives.
Yeah, no, thank you very much, because I think, the worst scenario is that we spend more money for intervention. We have no data to show that that money has a value, that really has provided, some benefit. And that will be, I think, the worst scenario, because we as a community with an interest in diabetes and obesity and the interplay will have no weapons to say, no, we did this, and that's what we achieved. This is what we provided.
Exactly, and I think there are also excellent examples of where you have done that, right? Where you've actually demonstrated clearly that early intervention matters, and that that was also highlighted in the presentation, that economically it makes sense to spend money with early intervention rather than treating expensive complications. And that's the kind of evidence we need.
Yeah, having said so, I think that you know better than I do, but I think that we all share the same impression that the current financial economic situation is probably not the best one, also because we are competing, unfortunately, with other, expenses. And I cannot, refrain myself to think how better could have spent money that are now spent in other devices. All right, let's call that. So, Georgios, under these constraints, how do you see, and also how the industry see the way to collaborate with the practitioner, with the medical community, in order to really try to bring these modifying approaches into the clinical scenario?
Thank you very much for that important and timely question, and also I'm grateful for the opportunity to be part of this panel. Indeed, we are operating within complex global environments, and in such a context, advocating for prioritization of chronic diseases such as obesity, diabetes, and cardiovascular disease can be challenging. But it is now that we need to show our commitment, reaffirm our commitment that these public health priorities need to be addressed. So as a first point, I would like to say that obesity in the context of diabetes is a complex multifactorial disease, and of course obesity and diabetes need to be considered in the context of other cardiovascular issues. It is important that as a second point, what I would like to point out is that we need a collaborative approach to problem solving, as you mentioned. This is critical. So we need to work together, partner, and advocate towards a collaborative approach. Additional point I would like to point out is that, to summarize, industry has a role in providing support with dissemination of information, education, and I would like to go back to obesity because this is what is dearer and closer to my heart. So obesity, contrary to popular belief, as Dr. Mueller mentioned, is not a choice, it's not a lifestyle choice. It is a chronic progressive multifactorial disease that is driven by biology, by genetic and epigenetic factors. And it is this belief that we need to try and change. So we need to populate high quality evidence, both in the clinical trial setting, but also in real world, in order to support proactive care, early intervention, and much needed interventions that will help control the disease of obesity and diabetes.
Yeah, I'm wondering, thank you very much. I'm wondering how fragmented is the approach to obesity and diabetes, across Europe. So again, an analogy for the discussion we had before for type 1 diabetes. We heard about it, building up clinics that really have different experts coming into the play, the immunologists, the diabetologists, and so on and so forth. So how we can envision, a metabolic clinic, I don't know how to call it, but a diabesity clinic or something like that. And again, that will follow the sort of suggestion that was coming from Timo, that we need to have a more unifying approach there. Jean-Francois, do you have any, what's going on in France? What do you do in France, for instance?
I think that the recommendation number 2 is very important, interdisciplinary. And I think also that we need a chief when you have so complex disease, and the chief may be also the nurse. We now in France, we have these high qualified nurses. We call them nurse de pratique avancée. That means that they are able to coordinate, to do some prescription, and they help us a lot. So I totally agree with you. So what we did, for example, in Lariboisière Hospital, but I think that you have some other examples like that. We have a center dedicated only for diabetes, and we have every day one of the ophthalmologists. We have one cardiologist. We have twice a week an hepatologist, and once a week a nephrologist. And instead of the patient, making the tour of the specialist, this is the reverse. This is a specialist that are turning around the patient. Also, we have nurses, we have, dietitians, psychologists. So I think this is probably the best way to have the most powerful integrated care for complex disease. And I know that, in Denmark, the Steno Diabetic Center, in the US, the Joslin Clinic, by the way, before doing it, in Lariboisière Hospital, we went to visit Steno, to visit Joslin Clinic. And I think, to my point of view, I think this is probably the best way to integrate care in such complex disease.
Yeah, definitely, I would personally advocate to have just one place or one clinic rather than having once again a person flipping from the obesity to the diabetes clinic to some extent, because that will generate even more stress for the people and probably generate more expense and more cost, because all these activities are not coming for free, of course. And so I was wondering, I was considering that maybe one action that could consider. I'd really like to hear your opinion also in the different setting of healthcare system. I think that the obesity clinic is something that has been, it was already there out there, but it was a very specialistic thing, and not that common. And most of the people with obesity very often were diabetics. So they were already going to a diabetes clinic. So I'm wondering whether we should really suggest or consider to generate, to educate within that structure people with a specific competence and experience in treating diabetes. Timo, what do you think?
You're absolutely right? When you historically think about a hospital that basically was specialized on helping obese patients, this was then primarily a hospital that was specialized on bariatric surgery, right? So, and in bariatric surgery, people didn't need so deep knowledge on the endocrinology that is behind all those modern weight loss drugs, right? So now basically the doctors in the hospital have another responsibility, which is to explain the patient why the drug is doing what it does. Why does the patient need to continue treatment, right? I mean, if you have a bariatric surgery, there is no continuation, there is no discontinuation of treatment, right? If your stomach is gone, it's gone, right? But if you take a drug and you stop taking the drug, or because the weight is plateauing, right, then it is our responsibility to explain the handling persons, like the nurses or the people in the hospital or even the patient, that at this point the drug did not stop working, that your weight is plateauing. Is the drug working? So if you discontinue taking the drug, then you will see what it means that the drug is no longer working, because then your weight will go up, right? So we have now the responsibility of the clinicians has changed in a way that we need to bring this knowledge to the patient. Why is the drug working? Why do I see the side effects that I see, right? It is our responsibility to, together with the patient, decide which drug is probably the best one for you in your particular case, right? And this has changed dramatically to the times where hospitals were primarily focused on bariatric surgery. And this will continue in the future, because we will in the future have a variety of different drugs. We will have drugs that are specialized for individual comorbidities, right? For example, the elderly, right? So in the elderly, the lean mass decreases naturally when you are above 50, right? So around 10% every 10 years. And so making drugs, especially for the elderly, where the weight loss is maybe not so dramatic, but at the same time, when you lose your body fat, you maintain or even increase your lean mass, right? So this can be one option. The other option can be that you, in addition to activating the incretin receptors, you send something to the liver to specifically induce liver lipolysis, right? Or maybe you even improve fibrosis in the liver, right? So the toolbox that we have has developed and expanded so dramatically over the last 20 years that we are now in a very luxury position that we can say, what we achieved already is so great. This was unbelievable for 100 years, right? I mean, also that we have obesity drugs that at the same time have cardiovascular benefits. I mean, remember the serotonergics, right? Yeah. They work half decently well on body weight, but they have a cardiovascular liability. Some of them induced pulmonary hypertension, right? So we are now in a situation where we can say, people would be super proud of what we achieved today, but it's not the time to lean back. This is now the time to switch gears, go into gear 3 or gear 4 maybe, and now make even better drugs, right? And I think we are on a very good trajectory here.
Please.
I think building on that, not related to the clinical setup, but back to the point about early screening and also early identification of which future products will be the right product for the right patient. And I think there's, from a healthcare system and a political perspective, of course, there's some anxiety about this huge problem. And so far, in terms of developing new products, we've had a relatively heterogeneous approach. We've basically taken a very heterogeneous population and developed new interventions for them. I think ideally in the future, of course, we will be much better at identifying which solution is the right one for the right patient, and who are the patients actually who have the highest risk, and how can we benefit them. And there we have an obligation, obviously, as industry, to be able to help you as clinician identify them. We've not been that successful yet, but I hope in the future that will change. And then to the other point on educating patients and providing support, I think there's also a growing awareness amongst us as pharmaceutical companies that solutions have to go beyond just the product itself. It's also about how can we help support patients and having them staying on treatment if it is required from a clinical perspective.
So if I may directly jump on this, because you are mentioning something that I, as a basic scientist, think is extremely an important message, right? Scientific progress starts very early, and this costs money, right? So I'm working with pharmaceutical industry since more than 20 years, and it's very, very important that companies not only focus on published work to make a product, a me too, right, to then get a certain share of the cake. It is a shared responsibility also of the pharmaceutical industry to talk to the scientists, to the clinicians, right, and to co-finance scientific progress where you later on benefit from, right? I mean, we have the Novo Nordisk Foundation, right? Lilly is giving a lot of money, and Lilly never left obesity research, which was also one of the reasons why the re-entry into the obesity market was fairly easy, right? How many companies left obesity research? Because there was apparently no hope, right? I mean, I can now tell you at least 10, I don't want to, but I could, right? But there is a reason why the market is currently what it is, because only Novo and Lilly and very few others basically stayed in the obesity market because they had a little hope that at some point somebody would pull a rabbit out of the hat, which happened, right? But what I want to say is that it is a shared responsibility of the industry to support scientific progress, and most of the pharmaceutical companies are actively doing this. I have to say, so that it is better, right? It is good.
And I think we are representing some of those companies.
Sure.
And I would say we see a huge need, of course, for reinvesting into future science, future research. That's part of the innovation-driven model that I think both of us, at least here, represent, and that we will continue to do.
And Georgios, I think that you want to add something.
Thank you. Yeah, I couldn't agree more. And in that principle, the principle of personalized medicine, we are exploring, and everyone is exploring. I agree with my colleague. The possibility of looking at subpopulations in the context of obesity and diabetes, and doing relative studies in that context. So I agree. This is a process of collaboration and shared accountability and responsibility. So I agree.
Yeah. Gabriel?
Yes, just to add that I think that you're right, we can do better, even as a primary care physician. I understand that, I said before, the value. Now we know that the early treatment really, and even when happens both conditions at the same time, pre-diabetes or diabetes plus obesity, really, now we are in front of a huge and important condition, and we are not used to attend this kind of people, at least not in a quite young adult population. We are mainly focused in older ones. So perhaps it's time to amplify our scope and to really, okay, so let's being more let's say, take a prevention attitude and proactive attitude. That's the word. So it's time to do that, because it's something new. We are saying, and we have good results since almost a decade before. So why do we have to wait more? So, and I think that it's something that I agree completely with all of you.
You sort of avoided one of the questions that I had in my list to ask you about personalized approach, but one comment, if you allow me, because one of the points also was, and I think you pointed that, is data collection. And I think that also collecting data, proper data, at the primary care level will help to generate data that may allow to really establish the different cluster or whatever, or personalization, or to understand, which is the one responding to what. And this, I think, is still, something that has to go on, and through research and support and so on, we need to have the data, and we have the data. And most likely, we also need to have the data of the study that you guys, the industry, is doing to be available for research or for more insight, in order to really take the greatest advantage out of it. Now, personalization also brings up another issue. The immediate differentiation is gender. And once, if you are not being good enough to intervene early and allow diabetes to develop in obesity, there is suggestion that it is more difficult to get these people losing weight. So really to have a comment from Eugenia first, because she has been working on that field, and then I would like to have the scientific look into that from Timo.
You want me first?
Yeah,
yes.
You go first.
Yes, we should address to this kind of problem to people's personality. We have to look for what are the preferences, what are their needs, so we can address, talking about obesity, what are the factors that contribute to this? This is the way of life. What is the factors we should take into account? We talk about mostly for patient-centered care. And we have to explain and to adapt treatment plan into people's needs, so they can be according to their preferences and the way of living. It's more...
But when you, Eugenia, when you make this kind of reasoning, do you take into account the gender, female, male? Is there any difference?
Yes, there are many differences. There are many differences in productive health, I can tell, but men have different way of thinking than women, and of course,
that's why my wife tells me all the time. Huh?
And generally, families are much more different than other families, depending on their socio-economic status. So we have to take into account all these factors so we can make a treatment plan which highlights their needs so they can better make adherence to medical...
So personalized plan that also facilitate the uptake of a pharmacological treatment if needed.
And we have to think about that person is not a disease, it's a whole person. So that is patient-centered care.
Okay. Timo.
Yeah, so personalized pharmacotherapies are the future. There's no question about it. But it is a double-sided sword, because unquestionably, the more we know about the patient, the better we can treat the patient. We made extreme progress in clustering, understanding patient heterogeneity, and now we are slowly trying to learn who benefits better from which therapy, from which treatment. However, and this will of course also further increase in the future, right? The more we know about the patient, the more likely it is that we can optimally help this patient. I think there's nobody disagreeing with this. The downside of this is something that requires a lot of attention from us scientists and from us in the society here, and this is that the patient cannot have a disadvantage. If anything, it has to be an advantage, but not a disadvantage, right? So nobody would guarantee getting screened for an ideal treatment if, in the case of a negative outcome, your health insurance would increase because you have 50 risk factors that we don't want to have, right? So we have a great responsibility, and this needs to be transported to the government, that a patient, if anything, can only have an advantage, right? The next thing is that the communication of the results with the patient is a very sensitive approach, right? Maybe we at some point figure out that if a patient has this combination of SNPs in his genome, gene XYZ, then he has only 10 years to live because he has a high chance to get a melanoma, right? So how do we deal with this, right? So this is a very sensitive field. It's a minefield we are walking on, and bringing the patient safely from one side to the other is an enormous burden and an enormous task for us, right? Of course, we only want the best for the patient, but there are also others who want to know everything and in order to save money and to increase health insurance costs, right? So this is a very, very hot topic.
Which really hits the one of the last points that Jean-Francois was talking about, equity. All right, so we need to make sure that we ensure equity now, but also in the future when things will be even more, better to some extent, but more challenging in general. I would really like to finish, this very interesting conversation with one concept that has been looming up time by time. Actually, it was mentioned directly by Jean-Francois, but it also came up on different aspects. Separation in terms of specialty or responsibility. Separation even more in terms of the money invested. So the silos theory. The silos theory has been around forever. Everyone is very critical about it, but we did not manage really to break this. So Jean-Francois, what is your view? What could be done? And really, I like to go around for a quick maybe response because we are left with the 4 minutes with this final consideration.
Yeah, I have a quick answer. I think it depends first line, second line, third line. I think we need to distinguish that. First line, I think the GP is totally, the chief, it's so important. And I think that we need to better organize the patient pathway between the first line to the second line, related to the complexity of the disease and the number of comorbidities. So this is what I would say. I say we cannot propose only one solution.
Let's go one side to the other so we can mix up the different competence here. Georgios, silos for you, what does it mean?
So if I understand the question correctly, you're referring to the multidisciplinary approach to...
It's silos in all things. It's in the way you manage the treatment, but also is how our system is allocating money. This is the money for obesity. This is the money for diabetes. And to my eyes, this is a limitation, it's a barrier.
Yes, of course. Of course. I agree with what's been said already. So I do agree that there needs to be an interconnected care, a multidisciplinary approach to how a chronic disease such as obesity and diabetes are managed. So there needs to be a clear pathway in the way people are referred from one specialty to another. I do see a very important role in primary care physicians. They are the ones who follow the patients chronically and they spend more time with them. So I believe that resources should be spent in a way that there's clear continuity of care for people living with chronic diseases such as obesity and diabetes.
Timo.
Well, there's not much I can add here, right? I 100% agree, right? So I think we all agree that we are working on a shared problem that needs to be solved jointly. We need to bring in the right expertises, the right experts to connect the right people in order to have an interdisciplinary approach to jointly treat a condition, obesity, diabetes, to prevent the development of comorbidities. And prevention is becoming more and more has a value that becomes more and more important, because if we react now with the tools that we today have available, we are able to prevent the onset and the progression of very devastating diseases, probably even expanding to neurodegenerative diseases that we don't even anticipate today, how much benefit this early treatment early on will have in the long run. And I think I mentioned this, who if not we, and when if not now.
And Herring, a comment also on the economical silos.
On silos, yeah. I think one way to view it is to think about what are the health gains for the patients, rather than thinking about which silo are we intervening in, right? So are we intervening in diabetes or obesity or cardiovascular disease? It actually doesn't matter, because what matters is the health gain that the patient has at the end. So somehow switching the incentive structure across healthcare systems, payer systems, and also for industry to focus on the outcomes, no matter which the ingoing disease is. That's a big ask, but...
Gabriel, your comment.
Yeah, I think that we are already, yes, we are siloed, the professionals. So it's sometimes even a matter of agility. We are not so quite agile as needed. And it's challenging, but we can do better, of course. We can implement a lot of tools, software, decision, etc. But I consider that the specific and specialized clinics that we pointed out before could be a management strategy to explore. It could be of interest with all the professionals in between the same setting, sharing their experiences, they really how to tackle the different problems. I think that it opens the door now that metabolic issues are growing up so much.
Eugenia, we decided that you are the core of the network and the integration process, so you have the final word.
Yes, I would like to add, let's join forces to tackle these twin epidemics, obesity and diabetes, through collaborative work. We can achieve many things, and everyone from a multidisciplinary team can share goals and communicate through common tools, so we can fight these two epidemics who go hand in hand.
And I believe that the EUDF and the action of the EUDF is an example of the collaborative effort. So I think that the same kind of spirit should really, animate any other effort, even in the daily clinical practice. We are come to the end of this symposium. I really like to thank all of you. Please, join me in a round of applause, because this has been, at least for me, a very informative and interesting discussion. I really like to thank all of you that have been here with us this afternoon. And I can only say one thing. We at the EUDF will not give up. We'll continue in this line of work to really try to improve the quality of life of people living with diabetes in Europe, but also outside Europe, of course. Thank you very much.